Okay, hello everyone. We are on the home stretch. I'm glad there's lots of light coming in that window because it's always hard to sit in a room all day. Hope you're all coffeed up and had a chance to chat. I can hear the energy in the conversation getting louder and louder every time we come back as people connect. So we've got 3 more of our research grant recipients to present this afternoon, and then Craig Martin, our Head of Evidence and Innovation, is going to facilitate a panel of those research grant recipients. And our first speaker of the last lot of speakers two are Glenn Hunter and Annette Peart from the Self-Help Addiction Resource Centre, SHARC, Turning Point and Monash, measuring the impact of group-based education and support for families coping with addiction. So if Glenn and Annette would like to come up.
Thanks, and hi everyone. Hope everyone's refreshed after a nice afternoon tea. Great to be here today. My name's Glenn Hunter and I'm the Breakthrough Project Lead at SHARC. And SHARC, of course, stands for Self-Help Addiction Resource Centre, and I'm part of the Family Drug and Gambling Help Team. I'm welcomed here today by my friend and research fellow Annette Peart. And I'd also just like to acknowledge the team that were part of this project, particularly Freya Horn, who's here today, and my co-facilitators, Anna Guthrie from Turning Point and Nikki Scarlett. So our project was measuring the impact of group-based education and support for families coping with addiction. So together with Monash University research team, we developed a strategy to evaluate the existing Families Understanding Addiction workshop and pilot a new online support group for families of the Breakthrough program. So Breakthrough is a joint initiative between SHARC and Turning Point, originally developed as part of Victoria's ICE Action Plan and focusing on ICE methamphetamine use. Breakthrough has evolved to focus on addictive behaviours more broadly, and it helps family members better understand drug use, improve communication and wellbeing, and access appropriate support. Breakthrough offers facts, practical strategies and support, and an opportunity for family members to connect and learn from each other. Go to the next slide. Are you doing this one?
Yes, that's me. So what we did with this project was we used some quantitative and some qualitative methods. And what I'll be talking about today is the qualitative methods that we followed. So we interviewed 21 Breakthrough participants who had completed Breakthrough in the last 6 to 12 months to understand their experiences of participating in Breakthrough. They were family or friends of a person with substance use or addiction issues, and they ranged from parents to step-parents, siblings, adult children, partners and acquaintances. The online support group was developed as an addition to Breakthrough. The Breakthrough participants were able to register and sign up for online support groups following Breakthrough. And 78 people attended the online support groups. 18 of them were held between August last year and April this year. We surveyed the online support group participants at baseline, and we asked them questions about social connectedness and wellbeing, for example. And then we interviewed 11 online support group participants to get more in-depth understanding of their experiences of the online support group. So for the Breakthrough participants we interviewed, all of them were women and with an average age of 53. So we've heard that a few times today. Most of them were concerned for their son, and methamphetamine ice was the primary drug of concern for over a third of the participants. Also, while most participants were from metropolitan Melbourne, we were also able to speak to people in rural and regional areas of Victoria. So when we asked the breakthrough interviewees about their experience of breakthrough, they talked about breakthrough's education plus the peer sharing of experiences enabled them to have their experiences validated, and it was destigmatising. We also found that participants moved from an approach where they described it as fixing or trying to fix the situation that was happening in their family to one of stepping back, and I've seen that in a couple of other presentations today as well. So through the education, they improved their understanding and they were able to make sense of what was happening in their lives, but also then change the approach that they were taking. We found that when Breakthrough went online, it actually helped reduce the barriers to access. When we interviewed people, they talked about attending Breakthrough sitting in their car, on their phone, or in a bedroom in their house, being able to access Breakthrough that way. Participants also talked about being able to be there online meant they didn't have to, drive across Melbourne and attend a face-to-face group. So it actually afforded them the ability to attend. The link from Breakthrough to the new online support group enabled them to consolidate the education that they received and provide that social connection. So I've just got a quote here from Eleanor. It's been a really helpful tool for me, and I think so for so many people it gives them some sense of hope and maybe control or understanding that wasn't there previously. They've given me a lot of confidence, a lot of understanding about the kind of decisions that maybe I should be making and the way that I can approach this. Yeah, a complex issue that's now a part of my world. Over to Glenn.
So the sessions that we ran were led by experienced facilitators, and they were open to the Breakthrough participants. And despite not being face-to-face, we found that families engaged really well in an online platform. There was a sense of that sharing in a safe space, connecting and giving feedback. We were able to reach families in need of support from areas all over Australia using the Zoom online platform. The teamwork and communication between the researchers and us as service providers was simply fantastic. From day dot, we met regularly and frequently, and because of that we were able to adapt and troubleshoot quickly, given the tight timelines and challenges that emerged. What we've learned is that when people are well supported and connected, positive change can happen. So for future groups, we considered that we need to think about how to engage people who aren't currently attending, such as males, as we touched on, and culturally and linguistically diverse communities. We also need to make consideration for people with physical disabilities. We had one participant who had some vision difficulties, so those sorts of things as well come into our consideration. As a facilitator and leader of this group, I was actively able to see the change in participants, and there was a real feeling of genuine connection. And this was evident at the conclusion of the project whereby participants expressed wanting this group to continue. And we actually have evolved it into another one of our groups at SHARC that we're running in order to give those families the opportunity to continue. It's been a real privilege to work on this project to support families in need, and such a terrific project team, and we look forward to taking the lessons from this project into the future. Thank you.
Thank you, that was great. I think it was another organisation as well where the research was done and the youngest age was 30. Is there any particular reason why youth wasn't included in that, or young adults that were under the age of 30 who would be in a caring role for maybe a sibling or a parent affected by AOD?
So when we recruited for the participants, it was advertised via Breakthrough. People who attended the Breakthrough sessions were invited to then be interviewed. So I guess it's a function of who Breakthrough is serving in that population anyway. So I'm not the person who delivers Breakthrough, but it's not designed to exclude certain people. It was the population that we had at that time. Not to say that young people do attend Breakthrough, but it was, I think, just at that point in time when we were recruiting, that's the people that we were looking at.
Thank you, that was very interesting. As you mentioned, your key lessons of being able to target males and reach more diverse backgrounds, have you actually addressed and thought about how you'll do that in future or for the next Breakthrough program?
It's a good question, and I think one that's been raised today. And I mean, look, engaging males, it's something that, you know, my manager Rob Campbell and I sort of have discussed as men. You know, I don't have the answers necessarily. I think that it's something for us as a collective, though, to really take out of today and have a think about ways that we can actively engage men. It's certainly something that I'm passionate about. But traditionally, as we know, you know, women go to the well and men go to the cave. You know, how do we overcome these sorts of challenges? It's not something that I have the exact answer to today, but yeah, keen to collaborate with everyone here and hear your thoughts about that as well. I think it's something that we can work on as a collective together.
We've found that there's a real siloed approach to research and program delivery, and you were saying that you worked really well together. And I was wondering, apart from the frequent meetings, what were kind of the elements that afforded you to have that, you know, great relationship? Because I think clinicians often think, you know, researchers are over there and researchers kind of think clinicians are over there. But I think you're the first people to say that we worked really well.
Yeah.
So just wondering what that looked like.
I think it's just having, for me anyway, having a real open dialogue and, yeah, just, you know, from the start, being able to meet, you know, discuss the project and what we obviously doing our planning, you know, and how we can effectively sort of do this. We worked out from the start that we were going to meet fortnightly, and we did that, you know, as a project team, and went back to, you know, they went back to the project managers, so we were able to implement sort of what the vision was. And I think just, yeah, having that open approach to things really worked well for us. Yeah.
Also, at the start there was sort of like, as researchers, we really wanted sort of, you want everything kind of black and white, like, you know, this is the plan, this is what's going to happen. And then the service deliverers are kind of like, well, this is what happens in real life. There's no way that's going to happen. So I think it's being respectful of what everyone can bring, and you can still do rigorous research if you are open to just maybe looking at things a little differently. But also, just with the fortnightly meetings, we all had them in our calendars, and, you know, if we didn't really have anything to talk about, then we'd just email and say, let's put it off till next time. But I guess if it's just there, it just reminds you that, oh, yeah, we've got a meeting, we've got to do what we said we would do. So, yeah.
Any other questions? No. Thanks.
I feel like my words this morning are just playing out in the presentations. We wanted the little neat research project, but the world's messy and we couldn't do it that way. So true. If we want research that's going to work in practice, we've got to work with the people who deliver those services. So great to hear that example. The next presentation is from Smart Recovery, from Dan, who, Alison's not here, is that right? No. So Dan's all on his own, building peer and provider capacity to effectively deliver smart family and friends meetings, a two-stage mixed methods evaluation. So welcome, Dan.
Thank you very much. Apologies on behalf of Ali Beck. She came down sick yesterday and subsequently told me that I was presenting it all, which I was not prepared for, so I've interpreted some slides written on my phone here. So hopefully I'll do them justice. If I don't do them justice, then just blame my accent. Or that it's quite late in the day, so you're probably quite tired anyway. So just acknowledge the traditional owners of the land that we're on today, past, present, and emerging, and I've come down from Brisbane, which is Quandamooka land in the Redlands area of Brisbane, so thank you for having us. And also just acknowledging the research advisory team that we have with Smart Recovery, who pretty much help us continue the great work and exist and be relevant. So thank you for those that were involved in this programme as well. As everyone here has already heard today and is aware, it's essential we continue to seek improvement regarding treatment and support options for family friends who may be affected by a loved one experiencing addictive behaviours. The current project is grounded in the potential peer-based services. Evidence supports the many benefits of services that harness the expertise of people with lived experience, both in the terms of services that are led by peers or provide an opportunity to support and learn from one another. Based on this, we were fortunate to engage in collaborative effort with University of Wollongong and Smart Recovery to provide mutual aid support groups for people affected by addictive behaviours. And the focus on the research was around building capacity of facilitators rather than, I won't be sharing much about the participant journey of it, which we can at a later date, but really just creating that capacity for facilitators to deliver the service. The current body of work was designed and build capacity of facilitators and SMART to meet the needs, as I say, of family members and harness the value of mutual aid support, peer-led provision, and develop and continue to collaborate the existing partnerships between SMART and the other service providers, which I know there's a couple of them here today. So it was great to meet you in person. In doing so, we also sought to generate new evidence and findings on how best to get a group like this up and running and sustainable. Just a brief overview, if you don't already know, Smart Recovery is a worldwide group support programme to help people make changes around problematic behaviour. It is the emphasis on self-management, effectively what SMART stands for. It's in 25 different countries now, and the weekly support groups, or the weekly groups that are run, are really focused in on just making practical changes that are really informed by a lot of principles that come through CBT and motivational interviewing. The actual Family and Friends programme, so I should say any Smart Recovery programme is run by trained facilitators. Normally it's a 2-day facilitator training course, and then you go on to do an additional training if you want to do the Family and Friends programme. And the Family and Friends programme is informed by Velleman and Orford's 5-step method of stress strain coping support model. And the Family and Friends is predominantly an 8-session course with a manual that you can run through. The facilitators that we trained as well had a digital, or hopefully some of them received in their Australian mail post. A lot of them didn't. Thank you, Australia Post. But there's a manual that you can systematically run through these 8-session courses, which is available on our website as well. The areas of supporting these groups really around motivation for change, coping with stress, self-care, assertive communication, setting strong goals and boundaries and problem solving, among some others. We aim to build capacity by increasing the number of groups available, generate new evidence to understand what ways helps and what ways peers and providers running groups. And we trained a new cohort of facilitators, peers and providers, and we found out that many of them work in the industry, have a personal experience or themselves or a family member, which is amazing. We explored the experience of training, support and facilitating the Smart and Friendliness programme. Predominantly this was through a qualitative study, but we also wanted to get a sense of how ready people felt to deliver the group. So after the training, the ALI completed a 3 subscales of the work practice questionnaire. Qualitative interviews were conducted over the telephone using a topic guide informed by, this is a mouthful, the Consolidated Framework for Implementation Research. There you go, it's fancy. This framework used 5 domains: intervention characteristics, outer setting, inner setting, characteristics of individuals and process, to classify and describe constructs associated with effective implementation of interventions. An overview of the preliminary findings of the services and facilitators we engaged in. We were successful in building capacity. We trained 24 new facilitators through a 1-day online training method for family and friends, including 16 people working across 10 services, and a further 8 volunteers have now been trained and have capacity to continue running these programmes. Some had said previously had done the 2-day foundational part of facilitated training, and then some had to all of them had to do the second part, the 1 day. The majority of people had both personal and professional experience supporting people with addictive behaviours, and already this is translated into 10 new groups which we've been running. 5 have been completed, 2 are due to finish in June, and the 3 have started or commencing in June, July. 2 facilitators and 1 of the services are already running the group again for a second time, and 1 of the volunteers have already started running their second 8-session courses. 1 of those groups was myself, as well as another volunteer that ran it. We also attempted to provide fortnightly support sessions after these trainings for the facilitators, and I think just sometimes it's difficult, as we've known, around capacity, work schedules, the time of the day that these support sessions, but we tried our best to, at least from my perspective, to have an open door policy around supporting facilitators and trying to respond to the needs that was coming through. The demographics of those who ended up doing the training, the peers or services, 25% of them had a personal experience, 8 professional, and 67% had both. So obviously they had personal and were working in the field. A higher percentage of females engaged in the training, and a general mix of professional experiences, as you can see there, which is great. So it's a very busy slide, and it's kind of all stretched. So the feedback received around training and delivery of the groups focuses on the main areas of role adequacy, training outcomes and training relevance. And the colours in the red and the orange highlight that they either disagreed or tend to disagree. But we're encouraged to see the 2 green colours. There's another grey. There's a couple of grey ones there. The 2 green colours represent and give some positive results around the confidence and the ability to run these groups after training. And the role adequacy, the further skills they've learned and equipped with, and also outcomes they received during the training, and how relevant the training was to them in their personal lives and also professional roles. The facilitators valued the structure and content of the intervention, and that the focus was on the effective family member. Mutual support was frequently raised as an important element of the intervention. And to improve the implementation in the future, we had useful feedback around potential updates to the programme. Factors related to culture of another organisational setting, staffing and other practical considerations were frequently raised. As we've heard today, capacity, staff levels, organisational priorities during COVID, different things like that. Speeding up now. This is where you really have to listen to the accent. Outside factors were frequently raised, including awareness of the programme, which has been challenging with historically low budget with Smart Recovery, covering the whole of Australia and New Zealand. And again, identifying the lack of availability for effective family members and some of the attitudes towards it. For example, many felt it would be a successful implementation because there is a lack of service, but the tendency for services to focus on people experiencing addictive behaviours rather than their family members. For groups that didn't get off the ground or had small numbers, many felt inadequate awareness, potential referrers, participants not understanding what the programme was, and participants' variables were at play. For example, not needing or not acknowledging the need for support, and we've heard again stigma and confidentiality concerns. There were many attending the actual groups, participants that came to get tips to get Johnny off drugs, which it was not what it's about. It's really about putting your own oxygen mask on before helping someone else. The feedback from both facilitators and participants, facilitators lived with experience supporting family members, were passionate about helping others and were comfortable with the level of training, also received some good suggestions how they can tailor that in the future. As we've heard just briefly, again, the engagement of participants, I think the challenges we experienced were awareness. In the last 6 years I've been with SMART, it's amazing to see the awareness that's continued to increase, but it's always a big challenge, and it's, we're really grateful for a lot of the organisations that collaborate with us. We haven't shared much about the participant journey, as I said, but we're happy to share that in the future. But overall, we're encouraged for the most part of what was achieved, in the sense that capacity for peers and providers to deliver SMART, and this continued beyond the end of the project. And for me, we have 24 facilitators now that we hope to continue to collaborate and keep running these sessions throughout the year and beyond. We also walk away with useful information around what not to do and things we can improve on, which is always helpful, and just improve general programme fidelity, programme awareness, and reduce any barriers to success. Any boring reading for the night, you can happily read that. But thank you. If there is any questions related to research, that's where I will look at you very blankly and pretend I don't understand your accent. Email Ali. But if you've got any questions around smart recovery, I'll sit here all day and talk about it. But thank you.
So any questions about the research?
Here's their email address.
Thanks, that was really interesting. I guess I just wanted to reflect on, I noticed your proportion of males were not too skewed, and I just wanted to talk about, sort of, given you, the program side, what are the best strategies that you have for engaging males that we might be able to learn from?
Well, I think there's two different aspects. We were talking about engaging people to facilitate these programs, and I think maybe it's anecdotally, as I said, not research-based. We tend to find there are a lot more females that engage in helping services. Maybe it's nurturing or whatever, I don't know. I think I was reflecting earlier about just engaging males in general, and I did a presentation around stigma at the New Zealand conference, Australian-New Zealand conference the other month there, and I think the stigma and the ability that guys are not meant to talk about their emotions, they're not meant to show weakness, they're not meant to, we're here to fix it, that's kind of the mentality. So I think we need to just normalise what these problems are. At SMART, we work really hard to try and destigmatise that. We don't necessarily want to be using disease or powerlessness kind of language, because there is an ability to change. So if people can start to influence media and policy and start having different dialogue and different discussions around it, then there's a possibility that males who are meant to have it all together are meant to have, whatever silly notions that they have. I think maybe that's a big part of why people don't reach out for help, possibly. So.
That's something I want to keep that conversation going, because it's something that ADF, we're very interested in being involved in with this group too.
Cool, thank you very much. Thanks.
Thank you, so many common themes. So our last speaker for today is Dr. Steph Kershaw from the Matilda Centre for Research into Mental Health and Substance Use from the University of Sydney. Steph's going to talk to us about the evaluation of the Alcohol and Other Drugs Family and Friends Support Program, a pilot study to assess acceptability and effectiveness in 50 families. Looking forward to it. Thanks, Steph.
Thank you, everyone. It's always hard to be the last presenter for the day, so I hope you all don't fall asleep. I would just like to start by acknowledging the traditional custodians of country throughout Australia and recognising their continuing connection to land, water and culture, and pay our respects to those who have cared and continue to care for country. So the Family and Friends Support Program, or FFSP for short, because we all love our acronyms, is an evidence-informed online resilience and wellbeing program for affected family members and friends who are supporting a loved one. It's a free program that can be accessed anywhere at any time in Australia. And it was developed with extensive input from affected family members and friends, a scoping review of evidence, and a guidance from a clinical research tree. There are 4 streams of the program, which are shown here. However, today I'm just going to be focusing on the stream which is about those who are supporting someone who's using alcohol and other drugs. So that particular stream, or as we call it, AOD FFSP, includes information and strategies for families and friends to support their loved one and protect them from the adverse effects of their lifestyle. But it also is designed for families and friends to provide them with improved resilience, self-care, communication and assertiveness skills. So FFSP has a number of interactive core and mini modules which are based on cognitive behavioural therapy principles, and they're also self-paced, so people can stop and start as they like and also redo any modules or activities at any time. And other features include videos from clinical psychologists and stories and quotes from people with lived experience. So this research project aimed to look at whether AOD FFSP was meeting the needs of affected family members and friends, and whether engagement with the program was associated with improved coping skills, reduction in distress, and increased perception of social and other support. So to address these aims, we wanted to recruit 50 family members and friends, and we asked them to complete a web-based survey at baseline, which collected demographic data and a number of other measures and validated scales to assess the impact of caring for a loved one with AOD use on distress, coping skills and social supports. We then invited the participants to interact with the program over 10 weeks, and then after this, we got them to come back and do another questionnaire which asked for feedback on the program's acceptability, usefulness, and also some repeated measures from baseline. And we wanted to see if there were any changes in those measures due to engaging with FFSP. We did offer the post-program survey to all family members and friends, whether they had actually interacted with the program or not. And then 4 weeks later, we asked them to complete a follow-up survey because we wanted to see if there were any improvements that had happened were sustained over the short term. And participants were also given the option of talking with a team member in a semi-structured in-depth interview. And this design ultimately allowed us to collect a range of quantitative and qualitative data. But it was the grand plan. The study is still ongoing, and I'll touch on why a bit later. So I am presenting very preliminary data, but we had 76 family members and friends who completed the baseline survey. However, of those, only 25 people, 33%, registered with the program. There were 33 people who completed the post-program survey, and of those, 22 completed the follow-up survey. So we did see quite a bit of dropout between the time points. Now, of those who completed the baseline survey, the demographics were unsurprising based on all the presentations we've seen today. Predominantly female, with an average age of 54 years. We had 51% coming from metro areas, and 78% of people said they generally access the internet via their smartphone. Most participants indicated that they were concerned about a child, so a son or daughter, followed by husband, friend or partner. And this is also consistent with some of the other results that we've seen today. The 2 substances of most concern were crystal methamphetamine and alcohol. So of the 33 people who completed the post-program survey, only 10 had engaged with the program. So I'm going to present the data on those 10 people. Now, in terms of usability, The program scored 70.8 on the system usability scale, which is higher than average, and we were quite pleased with that. And on a 5-point Likert scale, 7 out of 10 people felt somewhat, moderately or very confident and supported when facing alcohol and other drug-related issues after interacting with the program. I'll also just share the results of the K10 scale. And so, for those of you who don't know, higher scores indicate that people are in more severe distress. So what you want to see is the scores going down. So you can see that the mean score at baseline for the 10 participants was 31.6, which is in the very high range. And then this dropped to 29.2 in the moderate range. But as you can see, the standard deviation is quite large. There was also a very small decrease between the post-program and follow-up scores. But these numbers are quite small, and we're hoping that the extra recruitment will boost our numbers and we'll be able to do some more in-depth analysis. So what did we learn? Well, the initial recruitment was really well. We used social media and newsletters. We got a lot of people to undertake that baseline survey. However, there was then a challenge of getting people to engage with the program, and we had a high attrition rate. And this could be due to a number of reasons, because we did our baseline collection between sort of October and December last year, and then December was the great month where the Omicron wave hit. We then had floods, and everyone's also very busy at Christmas to be doing any programs. It could also be that participants weren't actually ready to commit to undertaking a program. We know that it takes time for some people to seek help and care for the needs, so it's possible that they clicked on the advert thinking that it was just a survey and that it was something they were really interested in, but then they didn't want to take that next step, which was engaging with the program. And this is a challenge for sort of real-life evaluations on type timelines. So what we've done is we've reopened recruitment and we've revamped our promotional activities to try and gather more data about the impact of FFSP. But we're still reasonably pleased with the data we've collected so far, as it'll give us some information into the impact of the program and how we might better engage people with it. So to finish, I'd just like to share 2 quotes that came out of the 3 qualitative interviews that we've done to date. So the first one is that these little vignettes of people's experience, they're very important, particularly the people coming to the site looking for something. When they see that, that's a huge help to have that when you think someone else is going through the same thing. And also there is a big role for online support to play because it helps people not feel so bad. Half the problem is people don't tell anyone because it's so shameful, particularly once they're an adult. So I'd just like to finish by thanking my amazing research team who've been involved throughout all of this project, particularly Professor Francis K. Lampkin. I'd also like to thank the Expert Advisory Group, our project partners, our national and international collaborators. And I'd just like to thank the Australian Government Department of Health for funding the development and implementation of the project, and the Alcohol and Drug Foundation for funding this evaluation. But most importantly, I really want to thank the many family members and friends who generously shared their stories and insights and feedback on the program. So I'm happy to take any questions. It was so good, I have no questions. Isn't anyone going to ask me about my female data split? Okay.
Did you manage to interview anyone who didn't engage with the program?
None of them actually wanted. Okay, so Aaron's question was, did we interview anyone who didn't engage with the program? We did contact them and ask them if they wanted to talk to us about why they hadn't engaged with the program, and they said either we didn't have time, we didn't realise we had to actually do the program, and also, I really wanted to, but lots of things happened. So I think if time had been on our side, we might have had a bit of luck, but yes, why can't people behave like lab rats and just go to that little spot? No.
Thank you. I feel like you sort of answered the question as you were going along with identifying what the reasons might have been for the dropout. How effective did you find the doing the follow-up survey as well? From, you know, obviously there was a decrease in the participating numbers as you went on, but instead of doing a pre-post, or would you do a pre-post moving forward, or yeah, just as the numbers continue to drop?
I would love to do the follow-up if it was effective, because it does help us understand if the improvements that people make at post-program are maintained. So is that interacting with the program, just having that initial change where they're doing really well, and then over time all the skills drop away, or are those skills being maintained? But yes. Many other factors, but ultimately, my design would be to continue on with the follow-up.